Okay, well, good morning and welcome to the 2024 Florida Health Literacy Summit, hosted by the Florida Literacy Coalition and sponsored by Sunshine Health. My name is Greg Smith. I'm Executive Director of the Florida Literacy Coalition. Today's summit is a statewide forum for educators, health professionals, and other interested stakeholders to discuss and share promising practices on how to effectively serve the health needs of adults and families with low literacy and low health literacy. About 1 in 5 adults in Florida have below basic literacy skills. And according to the CDC, approximately 90% of adults in the US face challenges at some point in their lives in comprehending health information. For the last 14 years, the Florida Literacy Coalition, in partnership with Florida Blue Foundation, has offered a health literacy grant program to integrate health education into adult education, literacy, and ESL instruction. We've seen firsthand how clear, direct, and candid communications on fundamental issues around health and healthcare can make a real big difference for the students we serve. Achieving positive health outcomes almost always necessitates clear communication between healthcare providers and patients. We need to find effective ways to reduce the gaps between the literacy demands of health care and health insurance systems and the health literacy needs of many Floridians. It is our hope that today's summit, in some small way, will be a productive step in that direction. I'd like to now take a moment to thank some of the folks who have been instrumental in making this event happen, starting with our planning committee. All these individuals were very instrumental in helping us to plan, organize, and promote this event. Almost all of them are also participating in the summit today as presenters or panelists. So thank you for all of you who have participated in this and really made this event possible. We really appreciate it. I'd also like to thank Allison Bell, who is our Health and Financial Literacy Coordinator here at FLC, who's also been instrumental in coordinating and organizing this event. And of course, I want to thank our presenting sponsor, Sunshine Health, that's making this possible today and making it possible to attend for free. So we really appreciate that. Sunshine Health and their Community Connections team do great work throughout Florida, cultivating partnerships and supporting worthy community-based organizations and initiatives. And with that, I'd like to turn it over to Camilla Brown, who was also on our planning committee, but her full-time job is Senior Director of Health Care Transformation at Sunshine Health. Camilla?
Thank you, Greg, and good morning to everyone, and welcome to the 2024 Health Literacy Summit. As he mentioned, my name is Camilla Brown, and I serve as the Senior Director of Healthcare Transformation at Sunshine Health. I am honored to be here and join you all today for this summit to learn and collaborate on how we all can best work together to serve the needs of Florida's families and adults with low health literacy and address the various barriers that they face daily. We know that Floridians who are unable to really successfully understand health information, they are more likely to have increased hospitalization rates, develop more diseases, and experience higher mortality. Each organization that's represented here today and those joining us online are vital to making sure we provide our state with the best care possible. There are several great sessions planned today where we will hear from some of Florida's leaders in healthcare. We will be having topics like health education and advocacy through storytelling, ChatGPT for plain language, writing for health professionals, promoting health literacy through interprofessional communication, and much more. A huge thank you to the Florida Literacy Coalition for hosting this summit and gathering us all here today. And thank you on behalf of Sunshine Health for including us in these important conversations that will be taking place today. And with that, it is my honor to introduce our keynote speaker this morning, Dr. Brian J. Zikmund-Fisher. Brian J. Zikmund-Fisher, PhD, is a professor of health behavior and health education, research professor of internal medicine, and associate director of the Center of Bioethics and Social Sciences in Medicine at the University of Michigan, Ann Arbor. He is also the editor-in-chief of journals Medical Decision Making and MDM Policy and Practice. A decision psychologist by training, Dr. Zikmund-Fisher is an expert in health risk perceptions and how to best communicate risk to facilitate health and medical decision-making. He examines how to make health data more intuitively meaningful to patients, the public, and policymakers alike. Studies the impact of people's consistent preferences for more versus less health care on over and underutilization of care, and explores the power of narratives in health communications. He is joining us this morning to discuss 3 questions to think about every time we give a patient numbers. We look forward to learning from this great session. And welcome, Dr. Zikmund-Fisher.
Thank you, Camille. I'm most grateful to be here. Let me just get my slides pulled up. Oops. Sorry about that. All right. So, as was sort of alluded to in my introduction, I am not so much a health literacy expert as I am somebody who thinks about how we communicate numbers and the quantitative information of health, and to enable people to use numbers to guide their decision making about all of the different medical decisions that we face in our lives. And when we're talking about numbers, let me give you some examples. So this is just a few of the different types of health numbers that patients might interact with over the course of their life, ranging from estimating their risk of getting a disease like breast cancer, to biomarker results like CD4 counts, to things like managing their diabetes, learning about the risks of colonoscopy, or other kinds of risk-benefit trade-offs that might be faced with health treatments or preventive actions, all of which we can quantify. But the question then becomes, if we have these numbers, why do we give people these numbers? And this might seem like a simple question, but I'm going to try and convince you today that it's not. Because when I talk to people about why they're giving patients health numbers, the responses I usually get fall something into this kind of space. Well, we need to inform people about their risk, and we help them know what the trade-offs are, and make sure they comprehend what their health status is, and all of that is good, and I don't want to minimize that. But what do we mean when we say understand or inform people about health numbers? I want to break that down for us today. And as was alluded to, I think the key when we're presenting health numbers to patients or to the public more broadly, there's 3 different questions that we need to remember on an ongoing basis. The first is, what outcome are we trying to accomplish? And I'll talk through what I mean by different outcomes. Second, to really reflect upon, are the numbers that we're providing, and in particular the formats of those numbers, in alignment with those outcomes, i.e., are they what the patients need to do what they need to do with that information? And third, have we contextualized the numbers? Have we enabled people to not only know what the numbers are, but to know what those numbers mean? So let's start with the first one. So I've been writing about this for a number of years. I've had a long-standing collaboration with Jessica Anker, who's at Vanderbilt. These are a couple of our papers. We've actually developed a taxonomy of the different outcomes of number communication. I'll just walk you through why I think this is so important. Because even if we look at things like comprehension, we can break that down into multiple different types of outcomes. It's different to say, can a person find the right number, versus Can they remember it? Or can they categorize that number? Or can they tell whether that number is larger or smaller than another one? Say, for example, by figuring out which of the side effects is most likely to occur if they're having looking at the risks of taking a medication. And that's not even getting into things like, do they perceive that number to be large or small? How do they feel about that number? Do they worry about that number? Can they tell what that number changes? And does that ultimately lead to behavioral intentions or to behavior? And in the end, do they trust it? All of these things are distinct outcomes. And the point I want to drive towards here is that we have to remember that as we're designing and thinking about what it is that we're giving patients when we're considering giving them numbers or not giving them numbers. So just to make this concrete, let me have you imagine that you're looking at a cardiovascular risk calculator. And of course, there's lots of these things out there. What do we want people to be able to do? Do we want them to remember the number, i.e. their likelihood of having a heart attack or stroke? Do we want them to believe that that calculator is trustworthy, i.e. that that number applies to them? Do we want them to know whether they're at high risk or not? And notice that's not the same thing as knowing what the number is. Do we want them to be persuaded to feel that that number is larger than they thought their risk was? Or do we want them to go see their doctor and take actions if in fact they are at high risk? Those are all different outcomes. Here's another example. Let's say we're talking to a patient about pre-exposure prophylaxis for HIV transmission prevention. Do we want them to remember the size of the risk reduction from that intervention? Perceive PrEP to be effective? Be less worried? Be motivated to use it? Or what? The point here is we can't have it all. There is no way of communicating health numbers that actually gets all of those outcomes optimally. And I really do mean this. Like, no, there's got to be, no, actually, there really isn't. If we design something that will help people remember the number, that's not necessarily going to be what motivates them. If we design something that's going to motivate them, that's not necessarily going to help them categorize it, etc. So we have to face that trade-off whenever we're designing communications of health numbers to patients or the public. Now, what that means is prioritization. We have to pick one. What matters most to us in a given situation? And so in the next section, I want to talk about how we ought to think about designing communications for different purposes. Do we give people the numbers that they need to do the tasks that they want to do, that they need to do to be healthy? So in one way to think about this is, on one side, we have, what does the audience need to do? They need to be able to, let's say, manage their diabetes, or they need to be able to be motivated to take protective action, like, say, cancer screening. And then there's what numbers can do, what communication can actually accomplish. And our goal as communicators is to find that sweet spot, the point where those two things converge and our communication is most likely to achieve the outcome that we want. So how do we do that? And I'm just going to give a little bit of background of the project that I've been involved with that sets the background for everything else that I'm going to be giving you today. But this is called the Making Numbers Meaningful project. It's been a massive review of the literature on health number communication. We've reviewed over 20,000 titles looking at health-related number communication, identified, if we're only just talking about probabilities, let alone test results, 316 articles on how to communicate probabilities, conducted very standardized evaluations of these, and thus far have identified over 1,000 distinct findings about how to communicate probabilities most effectively. What I'm going to do for the next few minutes is to give you a smattering of these findings, not because I can cover it all, quite impossible to do that in one presentation, but just to highlight a few of the things and to show you why I put so much emphasis on the question of knowing what your outcome is, knowing what it is that you're trying to achieve when you're communicating with patients. So, for example, did you know that if you tell someone that a side effect is rare, that actually makes them more worried than if you told them it happens in 1% of the cases? In fact, on average, people will interpret word, rare, to be approximately equivalent to about 9%. And if that's not the mapping that you wanted when you were trying to communicate the number, well, wait a second. If I tell them rare, do I want them to feel like it's a 5 or 10% risk? And if I don't, then maybe I don't want to use that word. I want to be using the number to make it more concretely clear to people that in fact we're talking about something smaller than what they think of as rare. And this is actually a big problem in the European Commission and the European Union, because they actually have a mapping that they're supposed to use for describing side effects as being common or rare or very rare, et cetera. And you see that mapping right here. But you'll note that rare here is even less than 1%. So that mapping doesn't seem to make sense in the way in which people are actually interpreting this. And in fact, what we've seen consistently is that these verbal terms result in higher perceived probability or higher worry and negative emotions, things like that, than people would have if they were presented with the same information in quantitative form, in percentage form, or 1 in X form, or common denominator rates. Now, speaking of which, did you know that if you say that there's a 1 in 100 chance of, let's say, a negative outcome occurring, most people perceive this as slightly bigger than if you tell them that there's a 1% chance of that thing occurring? Now, mathematically, those are the same thing. Percentage is out of 100, so 1 out of 100 is exactly the same thing as a 1% chance. But they're not interpreted equally. The literature on this suggests that when we use rates, 1 in 100, people focus in on that possibility of the 1, and that makes them pay more attention to it. They perceive it to be larger. Now, here's another question. Which of the following numbers represent the biggest risk of getting a disease? 1 in 100, 1 in 1,000, or 1 in 10? Now, this is a numeracy question. So literacy is the ability to process textual health information and understand the jargon, understand the words, understand its meaning. Numeracy is the analogous construct in the number space. So here we're talking about, do you understand how to use numbers to derive meaning? Now, hopefully you've looked at this and recognized that the largest risk is the last one, 1 in 10. That's a 10% risk. But it may concern you to know that 20% of a college-educated US sample gets this wrong. And it gets worse in lower education groups, and it gets worse in older populations. Why? Because you have to have the numeracy skills to recognize that the smaller the denominator, the larger the risk. And that's a difficult format for communicating risk. Here's another example of this. This is an old but classic paper from Grimes and Snively. Which risk is bigger, 1 in 384 or 1 in 112? When presented in that format, only about half of people actually get this right. But if you transform this into rates out of 1,000, 2.6 per 1,000 or 8.9 per 1,000, performance goes up. Because now all you have to do is look at the larger numerator and you identify the larger risk. This is what we call that contrast outcome, the ability to contrast one number versus another and to determine the larger one. And in this kind of context, using a fixed denominator as opposed to something that changes enables people to understand the number more consistently. And in fact, there's been multiple articles written, I have written some of them, to emphasize that 1 in X formats are really problematic unless our purpose is being persuasive. Because using 1 in X format, that 1 in blah, increases probability perceptions or feelings and decreases people's ability to contrast risks. So, you know, when I wrote about this 10 years ago, I actually equated this with medical malpractice. We know that communicating in a 1 in X format is confusing to people. We know that it biases their perceptions. There's no reason for us to be doing it. Now let's talk about a different format, you ever seen a graphic like this? It's a representation of probability. You see a 10 by 10 matrix of your people. What is this called? Well, I call it an icon array. And in the literature, we've often referred to it as things like pictographs. But part of the problem is that those aren't the only two words that have been used for this. In our review, we've identified, I think it is 32 different words or phrases that have been used to call the same graphic. Now, why am I highlighting this particular graphic? Because there's actually a lot of evidence-based research on using this to communicate probabilities to patients, whether that's their own personal risk of a disease or a side effect or something like that. So look at this. Do you perceive these risks to be the same? There's 8 little female icons there versus 8%. What I know from our review is that most people do not. They tend to see the 8 icons as a much larger likelihood than the number 8%. Now here's a different icon display. This one has that 10 by 10 matrix. Still shows 8%. But in this context, the 8% number actually tends to be perceived as larger than the 8% as shown here. So these things are not the same. And if what we want to be doing is to be amplifying perceptions, then maybe the display on the left might be useful. And if our goal is to show people how rare 8% is, let's say as a side effect, that 92% of people don't experience this, then the visual display on the right might be what we would prefer. And in fact, it even gets more subtle because people will remember a percentage if it's shown with little people icons better than if it's shown in the exact same display, but just with blocks. They'll remember it better, but that doesn't actually change their perceptions of the probability. Isn't that interesting? That just changing the icon, changing it to be a person, allows people to remember that number better. And this type of display is actually pretty much the evidence-based standard for communicating probability because it's particularly good at highlighting what we would refer to as absolute differences, i.e. the percentage of people who are different between 2 different options. So in this particular case, this is drawn from a paper that's looking at decision-making about adjuvant therapies for women who have early-stage breast cancer. You can see in a much more concrete way that adding chemotherapy to hormonal therapy in this particular case only changes the outcome for 1 woman out of 100. That the remaining 67 women are alive, regardless of whether they take chemotherapy, and that the other 32 women will unfortunately not be alive, regardless of what their choice is. The outcome is only changed for 1. And sometimes that's a really important thing when we're trying to communicate, does an intervention make a difference, either in the sense of increasing survival or other positive outcomes, or in terms of how much it raises our chance of experiencing a negative outcome, a side effect or a complication. And now you may be looking at these graphics and going, what is it? How can I do these things? I don't know how to make these things. And that's fine, because fortunately, there is this, iconarray.com, which is a free online risk graphics generator. This is something that we've built here at Michigan and have been making available to the larger community for about a dozen years. I encourage you, if you are interested in developing graphics to represent probability in whatever context that you might be communicating, to consider using these types of displays. It's highly individually tailorable. You can put multiple arrays into a set. You can do a variety of different things with it. Now, the last thing I want to emphasize is talk about context. And the reason I want to talk about context is to remind us that as much as we are health professionals, that we talk the language of health on a daily basis, that we are often familiar with the information that we're trying to communicate. Almost all of the people we're trying to communicate with are usually interacting with numbers that they don't see most of the time. And so the challenge becomes, how do we take a number and make it something that's actually understandable and useful to our audience? And so let me tell you a story, and this is a true story from my own life about how this kind of issue arises and why I think it's such an important issue when we're communicating numbers to patients. So a number of years ago, I was hospitalized, and I won't go into all of the details, but I was hospitalized for a long period of time, and having regular blood tests drawn to track what was happening to me from day to day. Now, I am a highly literate and numerate person, and so I was the kind of person who every single day was knocking on the door and saying, hey, to the nurses, and could I hear what my test results were? And sometimes when I started looking at them myself, even without somebody there. And as I was doing that, I got curious, like, let's see what this result is today. Let's see what this result today is. And one day, I looked at my results and I saw this, that my total bilirubin measure of liver function is 1.4. And what I remember from that day was that I remembered that that number was higher than what I thought my numbers had been previously. So I waited for rounds, and I waited until the attending doctor came in, and I said to my doctor, hey, I was looking at this result and it seems a little bit higher than what I've been seeing. Talk to me about this. And she said to me, oh, don't worry. I'll tell you when to worry. And I have to tell you, I was pissed. I was really upset because my experience as a patient was that I had information that I knew was relevant to my health. And I knew that it was different than what it had been before. And yet what my doctor was telling me, that I wasn't allowed to know what that number meant. And that to me is the core of the problem here. If we're going to give people numbers, we need to do so in a way that enables people to know what the meaning is. So let's dive into that. Recognizing that accessible numbers does not equal useful numbers. We have to make that leap, not just of providing information, but enabling people to derive meaning from it. So here's an example. This is a tabular result from a complete blood count. It's a little bit dated now. Most patient portals are starting to use graphical displays, and we'll be talking about graphical displays in a moment. But this is what I got. This is, in fact, a screenshot of a complete blood count that I got at one point in time in my life. And what does it mean to get this? How do patients use this? Well, let's start with what's the task that I'm supposed to be doing as a patient? Well, the first task I'm going to do is to figure out, is anything out of range here? Is anything not normal? Can you tell? Do the work for a little bit. I'll help you. There's three things here that are out of range. But notice that the task that each of us had to do as we were looking at this table, you had to know that your task was to look at your value and then compare it to this standard range thing that's sitting over in that column next to it, and to have enough numeracy skills to know whether the value fit inside or outside of that range, and then to put your attention on the situations in which that value was either below that range, as in the platelet count, or above that range, as in the mean corpuscular hemoglobin, and to focus your attention there. Does this matter? Well, actually it does. A number of years ago, I ran a study taking essentially this task, but presenting it for somebody who is trying to track their hemoglobin A1C value as somebody who is diagnosed with type 2 diabetes. And what do we see? Our ability to identify out of range values when they're provided in that kind of a tabular format is a function of both numeracy and literacy. So if you have, at least in our sample, relatively high literacy abilities and high numeracy abilities, you have a reasonable chance, but only about a 3/4 chance, 65, 75% chance of being able to take that tabular output and identify that your value was out of range. And if we go down to the population with lower numeracy skills and lower literacy skills, we're now down to about getting it right only about a third of the time. So that should really scare us. Like if we're going to be presenting numbers to people and 2/3 of a population we might be working with can't even tell us that number is out of range, what are they going to take away from getting the number in the first place? The concept here is called information evaluability. That's a big word, but it's a very simple experience. And it's best captured, I think, by this old Foxtrot cartoon. This is Jason. Jason's going to the gumball machine and he puts his money in and he gets 2 gumballs and he is ecstatic. He thinks he has beat the system because he's got 2 gumballs and he's so happy until he learns it was supposed to give him 3. And then he's mad. But notice, he still has 2 gumballs. His objective outcome is unchanged. But the meaning he assigns to getting 2 gumballs is fundamentally different. And that's the point. What we take away from a number isn't the number itself. It's how we compare that number to what we expect, how we contextualize it. So what do we do to help people understand the numbers that we give them? In addition to trying to know what it is we're accomplishing and to use the format that is going to be most aligned with that goal, we contextualize it. We provide context. Now, what do I mean by context? So here's different ways that we might contextualize health data. I've already shown you examples in which we give people normal or healthy reference ranges or standards. But there are lots of other things. So for example, when we give people, here's your risk with something and here's your risk without something, we can do the math for them. Asking people to do math is never a good idea. We can give them, here's what the absolute difference is. Remember that 1 more woman? That's the absolute difference. And by doing that math for people, we make it easier for them to understand it. In many contexts, we can give people targets, action thresholds. Once it hits this, we have to do something. Or once we hit this, that's where your goal is. That's what you're trying to achieve. We don't have those, maybe we use categories. Think like the categories we often use for things like cholesterol or blood pressure. Are you high? Are you borderline high, etc. By giving those categories, we transform the number into meaning. We can talk about range of variation. Simply knowing how much does a number change matters in helping people understand its meaning and clarifying what difference matters and what doesn't. So let me take the rest of my talk today and show you some examples of what I'm talking about. Let's talk about action thresholds. Here's a heart risk calculator. And in this particular case, 5.3% chance of having heart disease or a stroke in the next 10 years. What are you feeling about that? I don't know. I have no context. I don't know whether I should be worried about that number or not. But if we look at the recommendations from guideline creators, their guidelines suggested, oh, maybe we should have a risk of 10% or greater before we're going to do asking people to get onto a statin. And so all we have to do here is just add this on the basis of your calculated risk being under 10%. Guidelines suggest you would not likely benefit from starting aspirin. Now I know I don't need to take action because I haven't hit that action threshold yet. Think about range of variation and categories as ways of showing people the meaning of their health data. So here's a platelet count. Do you recognize that it's out of range? It's not necessarily very obvious, but here's that same data in a simple number line. It's a whole lot easier to see that you're out of range here, but it's also pretty clear that you're not really out of range. because part of what I've done here is to scale this line to represent the range of possible variation. And we can provide even more information when we move things into categories. So here is a hemoglobin A1C result, something that we might be giving someone to help them manage their diabetes. In this particular case, 6.2 is above the standard range. But how should I be feeling about that? Well, what if I give you categories? Now I have borderline high and high. I get to be able to place myself. Where do I fall in that range? But a subtle cue, as I've mentioned before, is to scale it. So look at these two graphics. They're both showing the exact same result, but they don't feel like the exact same result. The one on the top feels worse because we're further over to the right. And we notice that there's much more distance between me and the standard range. And so that's an unconscious thing, but it's part of the way in which we process graphics. So when we design graphics, it's not just is the number there, it's not just is it right, but what is the space that it's shown in? And because that also provides context. When we define relevant reference points, that helps people know, what should I think about my number? So here's an example. Here's a breast cancer risk assessment tool from the National Cancer Institute. My 5-year risk of developing breast cancer is 4.7%. What should I feel about that? Well, it's kind of useful to know what the average person's risk is for somebody your age. And in this particular case, that's a lot lower than the 4.7. And so I should be feeling, oh, wow, I'm above average. And I should notice that. We can also thinking about, well, wait a second, but both of those numbers are really small. Well, yes, that's true. But breast cancer doesn't just occur over, let's say, 5 years. It occurs over maybe lifetime. And so we try to talk about larger risks. Now let's talk about goals. Remember I was talking about diabetes? I don't necessarily want to get down to the standard range. If I have a goal range for people with type 2 diabetes, my goal range might be significantly higher than that. And we can give people that information and help them see, oh, wait, this is where I want to be if I have this diagnosis. I want a couple other examples. So here's a relatively unusual test, well, not unusual for medically, but most people aren't familiar with it, alanine aminotransferase. Let's imagine your value is 80. The standard range is 10 to 40. I'm a numeric person. I'm like, oh, that sounds like I'm way out of range. But maybe I'm not. You see, what I know is that most doctors don't get concerned until about 160. And so 80, while it's above normal, is not actually that concerning of a level. And by presenting that harm anchor, that reference point, I now get to calibrate on that value. And in fact, what we see consistently is that when you provide these kinds of reference standards, people are more sensitive to variations in their values. And that's what we want. We want people to use their numbers to inform what they're doing. Now, when I give this talk, people often come up to me and say, I'm really worried about bias. Like, I'm just trying to present people the numbers in the clearest possible way. I don't want to bias them. I don't want to push them one way versus another. Can't you just tell me how's the best way to communicate these numbers in a neutral fashion? One problem. Health data communications are always biased. There is no such thing as an unbiased way of presenting a health number. In fact, every way that we do it is manipulating people's perceptions in some form or another. Either we're providing some form of context, some reference standard, some category that's going to guide people towards a particular meaning, and yes, that is biasing them, or we're not, and we're leaving those people who don't have that additional contextual knowledge adrift, unable to know what their numbers mean for them, unable to know how that affects their health. So when I think about health communication, especially when I think about number communication, I go back to where we started today. What are we trying to achieve? What is the outcome that we're trying to achieve? And when we have clarity about that purpose, when we know what our goal is, then we can design the formats to optimize that outcome. Then we can pick the contextual information that best aligns with that outcome. And we're most likely to achieve what we want to see happen in the world. So those are my three main questions to remember whenever we're giving people health numbers, whether that's probabilities, whether that's lab results, anything like that. One, what is the outcome that we're trying to accomplish? Two, are the numbers what people need? Are they presented in the format that they need? Are they able to be informed in the way that supports their decision-making? And have we presented the context that's going to best enable them to do that task? All right. Well, let me stop there. Thank you very much for your time and attention. And it looks like we've got about, oh, maybe about 15 minutes for questions. So I'll be happy to take questions. And let me stop sharing my screen so that I can see people. So I am open to questions now. I'm happy to have people put stuff in the chat, or I don't know how you want to handle this.
Sure. We do have a question from Corrine. Do women have different numeric skills based on Grimes in Snively article?
So the Grimes and Snively article was looking particularly at a female population because they were looking at genetic risk in a obstetric context. But the literature regarding numeracy skills is pretty clear that it is not, I got to be careful here. In our society, there are biases in terms of how much numerical exposure people have, how much training people may have in numbers, and they're comfortable with that, which does relate, but not does relate to numeracy, but not as much as you think. This is not about education. There are lots of PhDs out there who are not particularly numerate, and there are lots of people who have pretty good numeracy skills, but are not highly educated in a formal way. So I wouldn't place too much on gender in this context. Numeracy is a fairly independent variable across the population.
Okay. Other questions for Dr. Zikmund-Fisher? And you feel free to unmute yourself if you'd like.
While people are thinking, I will respond to Marlene's comment about understanding what those tables mean. Tabular presentations are always difficult for people, especially those with lower numeracy skills, not just because they require numeracy skills to be able to find the relevant number and use the relevant number, but because people with lower numeracy skills turn away from numbers. If you have a written text and a table in it, somebody with low numeracy skills will skip over the table. They won't even look at it and read it. They'll just try and derive the information they can from the text. And by the way, the same thing is true in reverse for highly numerate people. Like I skim over text and I go straight to the tables. That's how I naturally orient towards picking up information. And we just have to be conscious of that and recognize that both the table and the text need to complement each other and to ensure that the same main takeaway is being communicated regardless of which format somebody is using to learn.
Good morning.
Good
My
morning.
name is Ethel.
Go ahead.
Dr. Zikmund, I truly enjoyed your presentation, and I want to ask a question. Where do we start in implementing? Where do we start to pivot to make a change as it relates to what you shared with us? Because I work in a public health setting, and I'm presumptuous that working in a public health setting versus working in a medical home would be different. But where do we start? What is our, what baby step could someone in public health do to kind of start making steps in the right direction?
Well, I think my first response is that I don't think that public health and medicine are different conceptually, but we do tend to use different types of numbers. So in public health, we might be less communicating probabilities of side effects and more communicating, let's say, um, disparities and differences in the risks between populations or case counts and helping people derive information from those case counts. Let me just say that from a public health standpoint, and someone who cares about number communication, the COVID-19 pandemic was fascinating. Like we were bombarded with case counts and all this data over and over again that supposedly was going to help us make decisions about what we should be doing in our day-to-day lives, but for the most part was just over our heads and not necessarily providing any useful context. And so that's, to me, is the answer to your question. What do you want people to do? And is a number actually going to be helpful in achieving that? There are times when, for example, I'm trying to work with people to explain just how different the risk of, I'm just going to pick a particular condition here, cardiovascular disease might be between people who live in one community versus live in a different community, to really highlight that disparity for the purposes of advocacy, for the purposes of motivating people to address that disparity. Being conscious of how do we create formats for communicating those numbers that are going to increase people's perception of the size of that difference. So using a constant denominator so we don't get any confusions about what these formats are. Maybe using visual displays that emphasize how big is the difference, even more than how big is the absolute mortality or the absolute rates of disease. The question really becomes, from my standpoint, one of self-reflection. Not assuming that just because we have a number that we ought to communicate it, but instead to taking a step back and saying, what is our goal as communicators in public health or in medicine? And then to only provide information in formats that are going to accomplish that goal. And it's a complex task, don't get me wrong, but if you ask what my baby step is, my baby step is to always ask yourself these questions. What am I trying to achieve? Is there some contextual information that would help somebody to know what this number means?
We have a question from Richard. He asked whether you engage in training healthcare professionals on how to be better numeracy communicators.
So in one sense, yes, and in another sense, no. I think of this less as something that needs to be solved at a interpersonal level and more as something that needs to be solved at a systems level. So rather than training doctors to communicate test results better, we change the patient portal to include graphics. So that everybody, regardless of their numeracy level, gets something that is easier to understand, that is more meaningful to understand. We develop patient education materials and decision support materials that present people their risks or the trade-offs that they face in ways that are maximally understandable to everybody. And let me be clear, there is no evidence that I am aware of that you need to do something different for highly numerate people versus less numerate people. Just because I'm a highly numerate person doesn't mean that I don't benefit when something is presented in a very clear way. This is the same idea as plain language applied to numbers. So if we think about our design, if we think about, do we even need a number in the first place? Like there are plenty of situations in which the right answer is, let me just tell you that your result was high and we're done. Let me just tell you that this value is above the action threshold and you need to take action on it. The number may not be important for many situations in public communication. Now, I say that and I will then walk it back because trust matters. And so hiding the numbers from people in contexts in which they may not have a lot of trust can undermine people's confidence in public health and in medical professionals. So there are times in which we provide numbers not because we're trying to communicate through those numbers, but because we're trying to support trust. And the primary communication will be through the category or other kinds of more verbal ways of communicating what that meaning is.
Okay, very good. I do know I've seen some programs where they've engaged adult literacy students in the process of reviewing some of these materials, since you're kind of looking at the universal design approach and trying to make sure it's accessible to everybody. There's a question from Martin. What are some strategies for teaching students in the health professions how to prioritize this thinking as part of their training for patient care?
Well, it's a good way. It's a good question. And honestly, it's the same question turned on themselves, at least as much as it is a question about how what they're going to say to the patients or the members of the public that they're working with. If you're a medical professional and let's say you're ordering a test, presumably you're going to change what you're going to do based upon that test. You ought to be able to articulate how high or low does this value need to be before I'm going to change what I do? What category would it need to fall into for me to take this action versus that? That's the core information that needs to be clear in your mind, because that's the core information that needs to be passed on to the patient. If my attendant had just said to me, yes, your bilirubin is a little bit elevated, but my action threshold is 2, and you're only at 1.4, and until we get to 2, I'm not going to need to do anything about this, I would have been completely happy. Because that would have told me not just what my number was, but how my doctor was thinking about it. And that's the conversation I think that all health professionals ought to be having when they're communicating numbers. Not just what the number is, but how that number will be used to support good decision-making, to support choices that will hopefully lead people in better directions.
Which gets to my point of how do you train them to do that so that they don't end up being like the doctor that you encountered?
Honestly, to me, it's an awareness issue. When I'm working with both public health professionals and with doctors, there's the term of art is a curse of knowledge. We're so familiar with the numbers, we don't realize how unfamiliar everybody else is.
Right.
So just simply saying, look, you may instantaneously know what's, I mean, I'm not mad at my doctor. Like, she didn't pause to think about what that 1.4 meant because its meaning was so transparently obvious to her.
Mm-hmm.
If we say, wait a second, you're responsible for contextualizing information. Your job is not done when you give people the number. Your job has to include some degree of context. Then I think that's all that's really required, because what the right context is will change from moment to moment, from test to test, from person to person. There's no hard and fast rules here, but the rules should be you have to provide some degree of context, and that context had better be well aligned with what you're trying to achieve in the first place.
Thank you.
There's a question from Evelyn. How do you best deal with the current social practice to select video learning versus reading? What recommendations do you have to help provide best avenue of understanding?
So I have various thoughts. One is I guess I'll put it this way. I am a communication minimalist. I don't always believe that bells and whistles support better communication. And in fact, in the graphic number communication world, there is a whole set of papers that have tested interactive visual displays of numbers and animated visual displays of numbers. And the takeaway from that literature is they make things worse because they distract you from actually focusing on the informational content of the video, of the graphic. Now, there's clear evidence that using a visual representation of number, those number lines or the icon arrays, does help people, in particular less numerate people, because numbers are not concrete without them. Like if I say 8%, you have to be actually numerate to like translate that number 8 into 1, 2, 3, 4, 5, 6, 7, 8 things. When we show people 8 things, that work is done for them. That's why visual displays of numbers work better. So the question of like, how do we deal with the social practice to do video learning versus reading? I sort of take a step back and say, it's just another variant of the same question. Like, video can be beneficial in the sense that it can support use of well-selected visual displays to highlight numbers when they are required. And at the same time, just because you have a video doesn't mean that you should throw a graphic in there. Let's think very carefully about what is our core message? What is the outcome that we're most seeking to achieve? And if the answer is, you're at high risk, maybe that's all we need to say. Now, maybe we throw in there a color or a graphic image that says high risk or an exclamation point or whatever. But from my standpoint, again, I keep going, I feel like I'm a broken record. And yes, I'm old enough to remember records. The clarity of goal is everything, not just in number communication, but in all forms of communication.
We have time for one more question. Is there an additional question?
Let me just follow up on Jessica's last thing that she just posted. Healthcare professionals should explain the health goal and how the numbers can connect to help them make decisions. You know, in many ways, we all ought to be doing this in our life. One of my favorite stories in my own life was when my wife and I intentionally did not do a test because we knew it wasn't going to change what we were going to do. And so why were we going to do a test if it wasn't actually going to change anything? And that clarity of purpose is at the heart, I think, of a lot of health number communication and a lot of health communication in general. When we know why we're ordering a test, fine. And if we don't have a good answer, maybe we shouldn't be ordering it in the first place. And that's a responsibility both for healthcare professionals and for patients to navigate.
Okay, very good. Well, thank you so much, Dr.
You're most
Zikmund-Fisher,
welcome.
giving us a lot of food for thought in terms of how we present numbers. Really need to be very deliberative about presenting numbers and graphics in ways that are useful and understandable to folks. That's something that I think people really maybe make certain assumptions about, as you pointed out, with regard to numbers being interpreted in different ways depending on how they're presented. So thank you for joining us and in sharing your research and your insights into this important topic.
You're most